Today we are going to learn about the drugs for bronchial asthma. Now in this class we will begin with what actually bronchial asthma is, and we will try to understand the pathophysiological aspects of bronchial asthma. And the purpose of understanding the pathophysiological aspects of bronchial asthma is to understand about the pharmacological targets, or to be more precise, we need to understand about the approach towards the treatment of bronchial asthma. And to have a better understanding about approach towards bronchial asthma treatment, we need to have a clear understanding regarding pathophysiological aspects of bronchial asthma. So let us first understand about what actually bronchial asthma is. Now there are various definitions of bronchial asthma as per the Global Initiative for Asthma, that is GINA. Bronchial asthma is a chronic inflammatory disease of the airways, and in this particular chronic inflammatory disease of the airways, there are many elements or various elements that play its role. And this particular chronic inflammation, what it leads to, this chronic inflammation leads to airway hyperresponsiveness. And because of this airway hyperresponsiveness, recurrent episodes of wheezing, breathlessness, chest tightness, coughing happens. And these recurrent attacks mostly appear during night or during sleep or in the early morning. And these episodes of breathlessness, wheezing, chest tightness, coughing, mostly these are associated with the bronchoconstriction or airflow obstruction. But the good thing is that in bronchial asthma, this airflow obstruction is, in most of the cases, it is reversible. It might reverse on its own, or sometimes it needs treatment. Now this factor, that this airflow obstruction is reversible, is in contrast to COPD. In COPD, that is chronic obstructive pulmonary disease, this airflow obstruction is basically irreversible, in contrast to bronchial asthma. In bronchial asthma, airflow obstruction is reversible either by its own or through the treatment. Now, what are the various types and causes of bronchial asthma? Broadly, we can categorize the types of bronchial asthma as intrinsic asthma and extrinsic asthma. Now, what is intrinsic asthma? Intrinsic asthma occurs in patients who don't have any prior history of allergies, whereas extrinsic asthma is also called as allergic asthma. In the allergic asthma or extrinsic asthma, the attack is mostly happening because of the exposure to the allergens. These allergens can be in the form of the dust mites, the animal allergens, or industrial chemicals, or any other thing. Then intrinsic asthma, as I have told you, in these cases patients do not have any prior history of allergies, but what we have seen that intrinsic asthma cases are usually triggered by either the upper respiratory tract infection or sometimes due to the psychological stress. Then there is one category of asthma, we call it as exercise-induced asthma, mostly seen in the adolescent patients, and as the name itself is very much clear, the attack in exercise-induced asthma is usually precipitated by the exercise. Now the next category of bronchial asthma is the drug-induced bronchial asthma. Drug-induced bronchial asthma, we had discussed in non-steroidal anti-inflammatory drugs that non-steroidal anti-inflammatory drugs can precipitate the attack of bronchial asthma by diverting the prostaglandin metabolites towards the lipoxygenase pathway. Then you have already learned about beta blockers. Among beta blockers, the non-selective beta blockers, they are more prone to lead to attack of bronchial asthma. But sometimes even cardioselective beta blockers in large doses, in higher doses, they might precipitate, but the chances of bronchial asthma attack happening is more with the non-selective beta blockers. And also, while we were discussing about cholinergic, anticholinergics, we have seen that cholinergic drugs usually precipitates the attack of bronchial asthma. There is one test, methacholine test, usually is done for diagnostic purpose in bronchial asthma. It is an obsolete test, but for theoretical reason you should know about that. So these are the broad categories of types and causes of bronchial asthma. Now, I was telling you about intrinsic asthma and extrinsic asthma. Now, there are certain allergens that might trigger the attack of bronchial asthma. These allergens can be in the form of dust mites, cockroaches, indoor and outdoor pollutants, or some irritants such as smoke, perfumes. Then some diseases, as I have told you, particularly the upper respiratory tract infection, can precipitate the attack of bronchial asthma. Sometimes GERD, gastroesophageal reflux disease, can also precipitate the attack of bronchial asthma. Physical stress or physiological stress can precipitate the bronchial asthma attack. Exercise, singing, laughing, crying, cold air, all these are the factors which can precipitate the attack of bronchial asthma. And the drug-induced asthma, we have already told you what are the drugs that can precipitate the attack of bronchial asthma. Now let us understand the pathophysiology of bronchial asthma. And the idea of understanding the pathophysiology of bronchial asthma, as I have told you again and again, is to understand about the drug targets, how drug can benefit in bronchial asthma. You can understand only when you have a clear understanding about the pathophysiological aspects of bronchial asthma. What happens in bronchial asthma? There is an inflammatory response to the allergens. Now, in response to that, broadly, there are two types of reaction that is happening: early reaction and late reaction. Now, in the early reaction, what happens? The antigen antibody reaction on the surface of the lung mast cell, it ultimately leads to rupture of the mast cell, and this rupture of mast cell release various mediators such as histamines, serotonin, prostaglandins, prostaglandin D2, and then leukotrienes such as leukotriene C4 and D4. And due to this early reaction, because of the release of these mediators, the bronchoconstriction happens. And also these mediators such as histamine, serotonin, leukotrienes, what they do, they diffuse throughout the airway wall and they also lead to vascular leakage. Now, what we are noticing in the early reaction or in the early phase, the predominant thing that is happening is bronchoconstriction. Okay, so one aspect of pathophysiology of bronchial asthma is bronchoconstriction. And as you can see in this particular picture, the release of mediators such as histamine, prostaglandins, leukotrienes. Histamine can lead to bronchoconstriction. It increases the vascular permeability. Prostaglandin D2 can also lead to bronchoconstriction. Leukotriene C4, D4, E4, they can lead to increased vascular permeability, mucus secretion, and also bronchoconstriction. So this is what is actually happening during the early phase reaction, that is culminating in bronchoconstriction. Now, one question to you is, can you rely on antihistaminic drug for the treatment of bronchial asthma? Say for example, a patient comes to OPD with the acute attack of asthma. Can you just prescribe him antihistaminic drug, and can you be very much sure that the patient will get relief? No. Why? Because though we have seen during the early phase, one of the mediators that is releasing is histamine, but histamine is not only the single mediator that is being released during the early phase reaction. There are other mediators also that is being released. Okay, so you have to take care of those mediators that are being released apart from the histamine, such as leukotrienes. But the use of antihistaminic can be helpful not in reversing the acute attack of bronchial asthma, but in some patients who are suffering from allergic rhinitis. Okay, and as I have told you, a patient who is suffering from upper respiratory tract infection, there are chances that he or she might suffer from an attack of acute bronchial asthma. So for those categories of patients, they might benefit to an extent from antihistaminic, but antihistaminic minded, it will not reverse the bronchoconstriction. And the other bad thing that antihistaminic can do is that it may dry the secretions in the upper and lower respiratory tract. So the bottom line is that antihistaminic drugs are not so effective in bronchial asthma. Then let us move on to the late phase reaction. Now we have seen that in the early phase, the release of mediator is happening, which is precipitating the attack of bronchial asthma, or which is leading to bronchoconstriction. Now, in the late phase, what happens? The infiltration of cytokine releasing Th2 lymphocytes, and there is also interleukin 4, 5, 9, and 13. What they does, they will attract and they will activate the eosinophils, and they will stimulate IgE production by B lymphocytes. So all these late reaction, what it will do, it will lead to airway inflammation, and this chronic inflammation will lead to airway hyperreactivity, and this airway inflammation, airway hyperreactivity along with bronchoconstriction is what actually seen in a patient who is suffering from bronchial asthma for a very longer period. So as I have told you, bronchial asthma is a chronic inflammatory disease, and what this chronic inflammation does, chronic inflammation, it leads to bronchial hyperresponsiveness. What does it mean? That it becomes very hyperresponsive to even very minor stimulus, or very small triggering event can lead to an attack of bronchial asthma. And on a long run, what happens? It leads to narrowing of air tubes. As you can see in this figure, there are two figures. One is normal air tube and one is air tube of patient suffering from bronchial asthma. What you can see in a patient suffering from bronchial asthma, there is narrowing of air tube mainly due to the contraction of airway smooth muscle or bronchoconstriction, and also this chronic reaction or the late reaction. What it does to it leads to formation of viscid mucus plug in the airway lumen, and also there is thickening of bronchial mucosa due to edema, cellular infiltration, and hyperplasia of secretory vascular and smooth muscle cells. So bronchial asthma, rather than calling it as a disease, we should call it as a syndrome. Bronchial asthma clinically should be called as a syndrome consisting of airway obstruction, consisting of bronchial hyperresponsiveness, and also consisting of airway inflammation. And the symptoms that is manifesting as a result of all these things is just, you can say, as a tip of iceberg, because what you are seeing as a symptom or as a manifestation of bronchial asthma is because of this chronic airway inflammation, because of that bronchial hyperresponsiveness, and because of the airflow obstruction. So what we have seen that airway inflammation for a very longer period will lead to swelling, thick mucus production, and there will be bronchial hyperresponsiveness because of this chronic inflammation. And what does you mean by bronchial hyperresponsiveness? Bronchial hyperresponsiveness means that the attack of bronchial asthma might be triggered even by exposure of even any stimuli or any triggering factor. And also there will be airflow obstruction leading to constriction of the bronchial muscles. But the good thing is that in contrast to COPD, most of the cases of bronchial asthma, this airway obstruction is reversible. So you have understood about the pathophysiology of bronchial asthma, and what you have noted is that in bronchial asthma, the important thing is the inflammation, the airway inflammation, and the airflow obstruction, apart from the bronchial hyperresponsiveness. So this early phase reaction or early reaction is actually culminating into bronchospasm, and the late reaction is usually leading to inflammation and bronchial hyperreactivity. So we can call, or we can say, bronchial asthma is a two-component disease. And if I call it as a two-component disease, it means that in one component we have the smooth muscle dysfunction, which is manifesting as bronchoconstriction apart from bronchial hyperreactivity, and there is respiratory tract inflammation, which is leading to inflammatory cell infiltration, mucous membrane edema, cell proliferation, epithelial damage, and the basal membrane thickening. So overall, this is what is happening. Though you cannot separate it as a separate compartment, the things will be overlapping here or there, but for better understanding we need to understand that these are the two things that is mainly happening in bronchial asthma. Now if I ask you which one is easier to reverse, like a patient who has come to your clinic with acute attack of bronchial asthma, the first thing that you need to think about is to reverse that bronchoconstriction so that patient actually gets the symptomatic relief. So this contraction of airway smooth muscle can easily be reversed by using bronchodilator drug. So one category of bronchial asthma drug is categorized as bronchodilators, and among bronchodilators, what are the drugs we will see just after few minutes. So the one aspect is to reverse the bronchoconstriction, and you can reverse bronchoconstriction by using bronchodilator. The second category is you need to take care of inflammation also, okay, but reducing the inflammation needs longer treatment, sustained treatment. So, and if you take care of that particular part or that particular aspect of bronchial asthma pathophysiology, what it will do, it will lead to reduction in frequency of attack and reduction in frequency of nocturnal attack to the patient. So this sustained treatment will actually lead to reduction in mucus hypersecretion, will reduce the thickening of mucosa due to immune cell infiltration. So to take care of the inflammation part, you need anti-inflammatory drugs. So now, if you have understood the pathophysiology, what we have seen, pathophysiological aspects of bronchial asthma. Bronchial asthma is a two-component disease. One is bronchoconstriction, one is inflammation. So if you relate these two to the aspects of treatment or to the component of treatment, we have two broad component of bronchial asthma drug. One is bronchodilator and another is anti-inflammatory drugs. So this is how we can broadly classify bronchial asthma drug into two broad categories, one as bronchodilators and one as anti-inflammatory drugs. So bronchodilators, what it will do, as I have told you, if a patient comes to OPD or a clinic with acute attack of asthma, you need to give quick relief to the patient so that the symptoms improves and so that the bronchospasm is relieved. So for that purpose, we use bronchodilators, and the purpose is to relieve the symptoms. So we can also call bronchodilator as reliever drug. Reliever, you means to relieve the symptoms or to relieve the manifestations that the patient actually have got at that particular moment. Then the second category of drug is anti-inflammatory drug. Anti-inflammatory drug, the purpose is to treat the inflammatory part or inflammatory aspects of bronchial asthma and to ultimately reduce the bronchial hyperreactivity, and so that the patient do not have a nocturnal attack, do not have a bronchial hyperreactivity, and he do not suffer from any future or any further attack of bronchial asthma. So we can say anti-inflammatory drug as a controller. Controller means to control the future attack or to prevent the attack. Okay. So we have two broad categories of drug. Bronchodilators, we call it as relievers or a quick relief medication. Then the second category of drug is anti-inflammatory drug. We call it as controller or control therapy or prophylactic therapy. Okay. So this is how you can categorize two categories of drug. And now let us see what are the drugs that comes under bronchodilators or the relievers, and what are the drugs that come under anti-inflammatory drugs or controller. So among bronchodilators, we have three broad categories. One is beta 2 agonist, then the other category is antimuscarinic drugs, and the third category is methylxanthines. So these drugs comes under bronchodilator, and I have told you bronchodilator can also be called as relievers or quick relief medication. Then among anti-inflammatory agents, we have corticosteroids, mast cell stabilizers, leukotriene antagonist, and anti-IgE antibody. So we call it as controller for a long-term control. So, two broad category of drug, bronchodilators and anti-inflammatory drug, or reliever and controller. Okay, in which case you will use reliever? For a quick relief of the attack, and controller to prevent the future attack. Okay, so we can now easily classify the drugs for bronchial asthma. So, bronchial asthma drugs can be broadly categorized into bronchodilators and anti-inflammatory. And in bronchodilator, I have told you there are three broad categories: beta 2 agonist, anticholinergics or antimuscarinics, and methylxanthines. And let us see the names. Among beta 2 agonists, we have short-acting beta 2 agonist and long-acting beta 2 agonist. Now, interesting thing that I will like to tell you, short-acting beta 2 agonist, we call it as SABA, is usually used for bronchodilation purpose or as a reliever, whereas the long-acting beta 2 agonist, usually we use it in combination with the anti-inflammatory drug, and this LABA is usually used as a controller, though it has got a bronchodilator action, but its onset of action is somewhat delayed compared to the short-acting beta 2 agonist, but its duration of action is relatively longer compared to the short-acting beta 2 agonist. So among short-acting beta 2 agonists or SABA, we have salbutamol, terbutaline. Then among long-acting beta 2 agonists, we have salmeterol, formoterol. Then anticholinergics, you have already read about anticholinergics which are used in bronchial asthma or COPD, such as ipratropium bromide or tiotropium bromide. Then methylxanthines such as theophylline or aminophyllines. Now in this class, I will discuss mainly about beta 2 agonists, both SABA and LABA. Then the next category of drug are anti-inflammatory drugs. In the anti-inflammatory drugs, corticosteroids are there. Now corticosteroids, mainly in bronchial asthma, we use inhalational corticosteroids. The idea is to get maximum benefit with minimal adverse effects. So inhalational corticosteroids such as beclomethasone, budesonide, fluticasone are used. Then systemic corticosteroids sometimes is needed, particularly in acute severe asthma or status asthmaticus. The systemic corticosteroids such as hydrocortisone, prednisolone, dexamethasone. Then we have leukotriene receptor antagonists such as montelukast, jafelukast. Then mast cell stabilizers, sodium chromoglycate, ketotifen. And then in the miscellaneous category, we have IgE antibody omalizumab. So about anti-inflammatory drugs, we will discuss in the next part or in the next class. And in this class, we will focus our discussion on beta 2 agonist, both short-acting as well as long-acting. So bronchodilators. What are the three broad categories of bronchodilators that I have told you right now? Beta 2 agonist, antimuscarinics, and methylxanthines. Very good. So among beta 2 agonists, we have short-acting beta 2 agonist and long-acting beta 2 agonist. Now, before moving further and discussing about bronchodilators, particularly beta 2 agonist, I will just give you a brief overview about the historical aspects of the pharmacotherapy of bronchial asthma. We human being is knowing about bronchial asthma since many thousands of years, and we have tried to devise certain therapeutic plan or certain treatment for the bronchial asthma. Actually, this word asthma is actually derived from a Greek word. Now, Dhatura is being used in India or in Indian subcontinent for various centuries. In Ayurveda, we usually burn the leaves of Dhatura species, and it was given for the relief of bronchial asthma attack. Now, one English gentleman, his name was General Gent. What he did, he got the idea, and he saw that in India, Ayurveda, we are using this leaves of Dhatura species, and we are using the inhalation of vapors of this Dhatura for the treatment of bronchial asthma. Now, what this gentleman did, he manufactured cigarettes containing Dhatura alkaloids, and he marketed it as a treatment of bronchial asthma. But later on, these alkaloids have been modified, and we have derived synthetic compound in the form of inhaled ipratropium bromide and tiotropium. These are the quaternary compound with limited systemic absorption. As you can see in this particular picture, the asthma cigarettes were being manufactured and being sold to deliver the Dhatura alkaloids. And what we have seen, these Dhatura alkaloids inhalation has got the bronchodilator activity. Then the second category of bronchial asthma drug or bronchodilators are methylxanthines. Methylxanthines are usually again plant compound, naturally found in tea or coffee. That's why any patients who are suffering from bronchial asthma, they get relief when they drink tea or coffee, and the reason is these compounds have got bronchodilatory activity. In fact, coffee is recommended as a treatment of bronchial asthma. Now then, there is one Chinese aspects related to it. The Chinese people, they were using ephedrine derived from the plant Ephedra vulgaris to make their Chinese preparation, which name was Ma Huan, and the purpose was to treat the dyspnea. And if you move further away from that particular part of history, or if you go towards 100 or 200 years ago, the researcher, they were trying the adrenal gland extract for treatment of bronchial asthma, and by 1903 epinephrine was being used for the treatment of bronchial asthma. And later on, we had injectable epinephrine, we had epinephrine suspension was being used, most particularly in the emergency management of bronchial asthma. But there were certain drawbacks that were associated with the use of epinephrine as far as treatment of bronchial asthma is concerned. I will ask you this question just after a few minutes. Now in this picture you can see the use of inhaled adrenaline to treat asthma. and this particular image is nothing but the early nebulizer. Now we have got the modified version of nebulizer, but this particular picture actually shows the earlier nebulizer, or the nebulizer when it was being used on those days. This is a particular picture of that. Then in 1950s, the first beta selective inhaled agent isoprenaline was developed. Now just see and try to understand why we have moved towards selective beta 2 agonist. Now we were using adrenaline, okay. Now there were certain drawbacks of adrenaline. What drawbacks you think about that? And then we tried to synthesize selective beta agonist, okay. And in 1950s we discovered isoprenaline, but by 1980s we were trying to discover, or we were trying to launch selective beta 2 agonist. What was the purpose of moving from a non-selective drug such as adrenaline, which is acting on both alpha and beta, and moving towards a drug isoprenaline which is beta selective, and then moving towards a drug which has got beta 2 selective action? What was the idea? See, if a drug has got both alpha and beta action, what you want a beta 2 selective action. You want beta 2 agonistic action for bronchodilator purpose. You don't want beta 1 action, or for that matter you don't want alpha action also, okay. So the selective beta 2 agonistic drug, by acting on only beta 2 receptors, they are only giving you the bronchodilatory effects. They are not leading to the cardiac side effects, okay. Drugs such as adrenaline, though they are very effective in the treatment of bronchial asthma or in the emergency management of bronchial asthma, but they can lead to cardiac side effects. The same is the case of isoprenaline. Isoprenaline, though it do not have any alpha action, but it has got beta 1 action, so it can also lead to cardiac side effects. But the selective beta 2 agonistic drug, by acting selectively on beta 2 receptors, they will only lead to bronchodilation, okay. Now before understanding little bit more about selective beta 2 agonistic drug, let us just understand about the physiological aspects or the neurohumoral control of airways. The normal tone of bronchial smooth muscle is basically controlled by the balance between parasympathetic and the sympathetic tone. And the third factor is the non-adrenergic, non-cholinergic activity, but we will focus on these two aspects, parasympathetic and sympathetic, okay. Parasympathetic stimulation leads to bronchoconstriction, whereas sympathetic stimulation relaxes the smooth muscle and leads to bronchodilation. So what we have seen, sympathetic stimulation is leading to bronchodilation and parasympathetic stimulation is leading to bronchoconstriction and increased mucus secretion. Now the thing is, among the sympathetic and parasympathetic tone, the predominant tone is parasympathetic. An activation of M3 receptor by the release of acetylcholine results in bronchoconstriction. And as far as sympathetic innervation is concerned, though sympathetic innervation of the airway is very less or very limited, but we have got beta 2 receptors on bronchial smooth muscle. And what this beta 2 stimulation leads to? Beta 2 stimulation leads to bronchodilation. And why this bronchodilation is happening? The basic thing is that because of beta 2 stimulation, there is increase in cyclic AMP. Okay, so this increased cyclic AMP is basically responsible for the bronchodilation. As you can see in this particular picture depicts the action of bronchodilators. Now what I have told you, that increased cyclic AMP actually leads to bronchodilation. Okay, so this bronchodilation by beta 2 agonistic is actually happening because of increased cyclic AMP. So you can lead to bronchodilation either by increasing the rate of its synthesis, increasing the rate of synthesis of cyclic AMP. Okay, so rate of synthesis of cyclic AMP or the increased level of cyclic AMP is happening with beta 2 agonistic drug. The other way of increasing the cyclic AMP is by inhibiting its rate of degradation or its rate of metabolism. Okay, and you can increase cyclic AMP by inhibiting its rate of degradation by phosphodiesterase inhibitor. Phosphodiesterase is actually an enzyme which is actually degrading the cyclic AMP. So if you inhibit phosphodiesterase, what it will lead to, it will ultimately increase the cyclic AMP. And also what we have seen that parasympathetic stimulation. So we have understood that bronchodilation is happening with beta 2 agonistic because of increased cyclic AMP. Bronchodilation is happening with methylxanthine because of phosphodiesterase inhibition. Phosphodiesterase inhibition is actually inhibiting the rate of metabolism of cyclic AMP. So there is increased cyclic AMP. The third drug, that is antimuscarinic, which is also a bronchodilator. What it does, what we have seen, parasympathetic tone or increased parasympathetic stimulation is basically leading to bronchoconstriction. So if you inhibit this muscarinic stimulation or if you inhibit parasympathetic stimulation, you can lead to bronchodilation. So what we have seen, the beta receptor agonist, they act by increasing the cyclic AMP level, and this increased cyclic AMP level in the bronchial smooth muscle leads to relaxation of bronchial smooth muscle. The second thing is that the stimulation of beta 2 receptor on the inflammatory cell, it also leads to increased cyclic AMP on the inflammatory cell, and they inhibit the release of various mediators that is responsible for the attack of bronchoconstriction, and also they inhibit the release of cytokines. Now let us understand the events that is ultimately leading to bronchodilation. And the other thing is that why beta 2 agonistic drug have got negligible anti-inflammatory effect. Though they are stimulating the beta 2 receptor on the inflammatory cell, they are increasing the cyclic AMP on the inflammatory cell, and they are ultimately inhibiting the release of mediator and cytokines. But why they have got very negligible or nil anti-inflammatory effect? The reason is because the receptors on the inflammatory cell, they get desensitized very rapidly, and because of that they are very little effect in inhibiting the airway inflammation. So what we have seen, this increased cyclic AMP, what it does, it activates the protein kinase A, and this protein kinase A phosphorylation, it leads to phosphorylated myosin light chain kinase MLCK, and this phosphorylated myosin light chain kinase have a decreased affinity for calcium calmodulin complex. So ultimately there is decreased activity of smooth muscle actin myosin and leading to relaxation of bronchial smooth muscle. Now Next thing that you need to understand, can you use these short-acting beta-2 agonists for a very longer period without any interval or without any interruption of the treatment? Can you use these short-acting beta-2 agonistic drugs for a very longer period? No, because what we have understood in pharmacodynamics, if you use agonistic drug for a very longer period, what it will lead to? It will lead to decreased receptor number and or the down regulation of the receptors. So this down regulation of the receptor will lead to decreased drug effect. So chronic use of short-acting beta-2 agonistic drugs such as salbutamol will actually down-regulate the beta-2 receptors. So that's why you will see that if a patient who is regularly using these short-acting beta-2 agonistic drug for a chronic period, for a longer period, gradually the response will start decreasing. So what we have seen, we can classify beta agonistic as beta-2 selective and non-selective. Nowadays we are mainly using the beta-2 selective drugs, and the reason of not using the non-selective drugs is what? Why we are not using the non-selective beta agonistic drugs? Yes, because of mainly to avoid the cardiac side effect. Because if you see the location of beta-1 and beta-2, beta-1 is mainly located in the heart tissue, whereas beta-2 is mainly located in the bronchial smooth muscles. And as you can see in this particular table, epinephrine or adrenaline, apart from the alpha action, it has also got beta-1 action, that is undesirable. Isoprene, though it do not have any alpha action, but it has got beta-1 action, that is also undesirable. Whereas drugs such as terbutaline or albuterol, they have negligible beta-1 action. Their main action is on the beta-2. So adrenaline, though they have got very prompt and powerful bronchodilatory action, but their use nowadays has declined because of better availability of the drugs or availability of better drugs, and because of the serious cardiac effects that can happen with adrenaline. Now let us discuss about beta-2 agonistic in a little detail. We can further classify beta-2 agonistic drug as short-acting beta-2 agonistic drugs and long-acting beta-2 agonistic. In short, we call it as SABA and LABA. And what do we mean by short-acting beta-2 agonistic drug? Short-acting beta-2 agonistic drug have got rapid onset of action. But though they have got rapid onset of action, they have got very short duration of action. Their duration of action will be lasting up to only 4 to 6 hours. Okay, though their onset of action will appear within 15 to 30 minutes. So they can be used as a reliever for a quick relief of bronchial asthma symptoms. So these drugs can provide you symptomatic relief, okay, during the acute attack of bronchial asthma. But the long-acting beta-2 agonistic drug, though they have got bronchodilatory action, but their onset of action is delayed compared to the short-acting beta-2 agonistic. But the good thing is that their duration of action is prolonged. Their duration of action is more than 12 hours. If you see the duration of action of short-acting beta-2 agonistic drug, it is only up to 4 to 6 hours, whereas the duration of action of the long-acting beta-2 agonist is more than 12 hours. So because of their delayed onset of action, you cannot use it in acute attack of asthma. You cannot use it as reliever. You cannot use it for the quick relief of bronchial asthma symptoms, but you can use it as a prophylactic agent. for control of symptoms or prevention of asthma symptom. Mostly we combine these long-acting beta-2 agonistic drugs with the inhalational corticosteroids. So among short-acting beta-2 agonistic, we have drugs such as salbutamol, terbutaline. Among long-acting beta-2 agonistic, we have drugs such as salmeterol, formoterol, bombetrol, clenbuterol. So what we have seen that short-acting beta-2 agonistic drug, both short-acting and long-acting, they are increasing the level of cyclic AMP, and that is how they are relaxing the bronchial smooth muscle. But the thing is that the onset of action and total duration of action is different. For short-acting beta-2 agonistic drugs, the onset of action is within 15 to 30 minutes, and the total duration of action is up to 4 to 6 hours. So these drugs, either you can use it to prevent the exercise induced bronchial asthma. If you are very much sure that when I do exercise I get an attack of bronchial asthma, but even in that case it is better not to go for these drugs, rather to go for the prophylactic agents, because long-term use of these drugs will ultimately down-regulate the receptors and will lead to decrease in effects. And to get optimal benefit from these drugs, it is said that they should be used as and when required. They should not be used on a regular basis. They should only be used when the patient has got a acute attack of asthma and when he or she needs quick relief of symptoms. And mostly we give it by inhalational route. And the idea of not preferring oral route is to avoid the systemic side effects such as the cardiac side effects or the tremors. Though these beta-2 agonistic drugs, they are very well tolerated when given by inhalational route. When given orally or when used in a very higher doses, they can lead to muscle tremors, they can lead to tachycardia, palpitation, sometimes they can lead to hypokalemia. But overall they are very safe. And why we do not prefer oral therapy with the beta-2 sympathomimetics? Because of the greater chances of adverse effect happening, particularly the cardiac adverse effects or the muscle tremors. Or sometimes you need oral therapy if patient is too young and the patient cannot manipulate the inhalational device. So in those cases, you might go for oral therapy till a patient till a point comes when a patient know how to use that device. Or oral therapy is needed sometimes in cases of acute severe asthma or status asthmaticus. Then the next category is long-acting beta-2 agonistic drug such as salmeterol, formoterol. In contrast to the short-acting beta-2 agonistic, they have got slower onset of action, but their duration of action is even more than 12 hours. And mostly they are used as a controller in combination with inhalational corticosteroid to decrease the number and severity of bronchial asthma attack. The thing is, these long-acting beta-2 agonistic drugs, they produce bronchial smooth muscle relaxation, but they have got very negligible anti-inflammatory effect. Whatever anti-inflammatory effect they have got, because the receptors on inflammatory cells, they get desensitized very rapidly. So these drugs, they have got very little effect in inhibiting airway inflammation. So mostly the role of long-acting beta-2 agonistic drug in bronchial asthma is usually you have to see in the context of inhalational corticosteroid. We usually combine long-acting beta-2 agonistic drug with inhalational corticosteroid, and we usually use it to prevent any future attack or any further attack of bronchial asthma. One aspect of combining long-acting beta-2 agonistic drug with the inhalational corticosteroid is that in the initial part of the class I have told you bronchial asthma is a two-component disease, wherein you have to take care of bronchoconstriction and you have to take care of inflammation. So with the long-acting beta-2 agonistic, at least you are taking care of the bronchoconstriction part, but it cannot be used to relieve the acute attack of asthma because its onset of action is slow. And if you combine it with inhalational corticosteroid, you will get added benefit of targeting the anti-inflammatory or getting the anti-inflammatory benefits. So we have various combinations of long-acting beta-2 agonistic with the inhalational corticosteroids such as salmeterol, fluticasone that is available in the market, and it is advisable that rather than increasing the dose of corticosteroid to get the desired benefit, it is better to combine corticosteroid with the long-acting beta-2 agonistic drug and to use it to prevent any future attack of bronchial asthma. So what happens if you combine the inhalational corticosteroids with beta-2 agonistic drug? You get a synergistic effect, and they interact with each other to potentiate their actions. What steroids does, steroids actually increase the transcription of beta-2 receptors gene in the airway mucosa. The second thing that they does, they actually prevent the down regulation of beta-2 receptor, and in fact they increase the up regulation of the beta-2 receptors in the lung cells. Whereas beta-2 agonistic drug, they enhance the binding of glucocorticoid receptors to the DNA, and they increase the translocation of glucocorticoid receptors to the nucleus. So what we are noticing is that they are actually potentiating their action. So that's why the combination of inhalational corticosteroids along with this beta-2 agonistic drug or long-acting beta-2 agonistic drug is in fact the first choice drug for chronic asthma, and the purpose is to prevent any future attack of bronchial asthma. Okay, so we will continue our discussion in the next class, wherein we will learn about the other bronchodilators and also about the anti-inflammatory drugs.